So really, what's in a name? Complex. It's a challenging condition. It's got multiple systems. Regional. It's in an arm or a leg normally, but not always. Pain is the predominant symptom, and we use the term syndrome because it probably is actually a couple of conditions that all fit under one umbrella. But at the moment, this is the best diagnosis I've got. It's characterized by pain, temperature changes, skin sensitivity, color changes, hair growth, nail growth, swelling, edema, sweating, and what we call motor dysfunction. So there's a picture of somebody with dystonia, but weakness, stiffness, a joint just not moving. Probably for what we just heard, it's also a condition that has quite a strong reputation amongst clinicians as well. And Debbie and I have certainly heard all sorts of nasty things by our peers about this, which we want to try change. It's really hard to diagnose. So as you said, staff don't really know what they're doing. We know a survey of 240 odd people that worked in pain services really struggled to identify the symptoms. It's really hard to treat. The 2024 Cochrane Review told us that really not much worked for anything, which is upsetting. And probably the thing that sort of stimulated my research project was this reputation in society. So a really quick Google will tell us, about amputation of a limb. Stuff is so bad for this, I must say. The suicide disease. This is from the Daily Mail in the UK. And, my favourite quote, it's the highest rated pain disease in the world. How do we do? I know how they found that, but it seems a bit ridiculous. Outranks amputation, childbirth, broken bones, more painful than cancer. It's nicknamed the suicide disease because a high number of people commit suicide after being diagnosed. Now, just imagine being in a pain clinic. We see a patient and we give them a diagnosis. We think you've got complex regional pain syndrome. So the first thing we do is we go online and we Google what that is. And these are the things that come up on the first page. I'm used to the view knowing what comes next. So just forgive me if I need to rethink what I'm saying here. What I thought we could do is we could give you some facts about this, just to set a bit of a background. What we do know is that 96% of the people that are diagnosed with this condition at 1 year will have ongoing symptoms. So what that looks like is a bit difficult to determine. It's often pain, it's sometimes motor loss, sometimes sensory changes. But probably more importantly, we do know that about 40% of people return to work in one study. About 2/3 of people go back to work in some format with adaptations, reduced work or maybe reduced activities. But we don't hear much about this in the literature or the data. What we know anecdotally in the pain clinic is that there are people that come to our clinic and some people just do really well and some people don't. And you probably are thinking, well, it's to do with how much pain they've got or how severe the disease is. But the reality is that's not really the case. We know on back pain data, we see disability measures don't correlate to findings and physical factors. We see the same thing in CRPS. Good example is this bloke. This is a Welsh gentleman who was diagnosed with CRPS and talked about waking up paralysed, not being able to use his legs, with the use of crutches and walking knee supports. He climbed Everest Base Camp. So Debbie and I kind of sat down and thought, what is it about this guy? What is it about those guys in our pain clinic that have this condition that has lots of data saying we don't do it very well, society tells us it's really difficult to live with, but some people just manage things really well. When we look at the qualitative literature, it always has the same theme to it. It's always about what went wrong, what we didn't do, how the system stuffed me up. I think these things are really important for us because we can learn from them and we can make changes. But we possibly are missing a really large proportion of these people that go back to work, that manage, that go to Everest Base Camp. And there is no study that looks at these people. So we thought, let's try give this a go. And it raises a question now, how do we find people that are living well with a chronic pain condition? Any ideas? They don't sit in our pain clinics. They don't sit in the waiting rooms. They're not in pain management programs. They're often not even getting treatment, but they still have daily symptoms. They still live with a condition. Any idea?
Yeah, exactly.
First question we've got to ask is what do we mean by living well? And I can, the peer reviewers and the guys doing my ethics were all over this. What does that mean? The reality is this: we don't know what that means. We looked at our the way we sort of designed our study. I've forgotten all my terminology around ontology and everything now. Once you hand in your thesis, it just goes. But we felt that if somebody viewed they were living well, they were living well. It wasn't up to me as a clinician to look at psychometrics and disability measures and go, I think you're living well. As I said, anecdotally in the pain service, somebody might arrive in a wheelchair, unable to move their legs, yet that person considers themselves to be living well, then they're living well. It is different to well-being. This probably focuses more on a broader spectrum of things. It's certainly coping as a feature of living well, but coping and living well aren't the same thing. Just because we have less distress or we're managing pain better, it doesn't necessarily mean that we're thriving. Resilience seems to be a feature in living well literature, so maybe that's something that people have. We thought maybe acceptance was maybe a prerequisite to living well, which we can talk about in a minute. This idea of self-coherence, and the psychologists will know that a bit better than me. So we know if somebody has a really strong self-concept and they can work towards that and have the ability to, they're probably more likely to be living well. So I thought you guys might be interested in this, being academics. This was our research team. So Debbie was excellent. We also worked with a lady, Bronnie Thompson in Otago, and we were lucky enough around the time is when the co-design of people living with pain became really important to have within research design. So we approached Katie, who was an Otago uni student who supported us through several phases. So we looked at design. We did a questionnaire, which you guys are well familiar with. We set up a website with all the information. After approval, we went to social media because we thought that maybe that's the way people get it. I don't think we got a single person through social media. So we used Twitter and Facebook and not much came from that. What we probably got was the word of mouth style thing. So there's our Pain Society, our publication, and we located one or two people through there, and then they knew of somebody and so on. And then we also sent our requests out to a New Zealand-based CRPS research database. So when we got our participants, we thought it was going to take ages. We gave it a year or so because we thought, finding 10 people living well with this condition might be really, really difficult. And actually, we got them really fast, probably within the space of 2 months. And what we found was probably that these people that aren't in research, that don't want to be in pain clinics, they were so keen to tell us the story. And they, of course, knew someone who could then do the same as well. We took some screening measures, some psychometric ones, but that was just to characterize our sample. And our main data was semi-structured interviews. And you guys will be well familiar with reflexive thematic analysis, but here's an example of some of the familiarization notes and some of the coding we did through Word, Debbie and I, and then the 4 of us, or the 3 of us, theme generation, and Katie sat with us at the end to make sure that it had resonance of the person living with pain or living with CRPS. So we wanted to know, you could be in our study if you had a formal diagnosis of CRPS. We won't go into type 1 or type 2, but it doesn't matter. Were you diagnosed more than a year ago? So this is a condition we know within the first 12 months. If it's going to resolve, it resolves. We don't really want to get someone that has a diagnosis and then a month later, once they're in it, it disappears. We want them to still have symptoms. I can't remember, we set something like 3 days of the week, or we set some margin like that. Are you over the age of 18? And for the peds guys, I'm hearing Pediatric CRPS seems to be a little bit different. Is it a different trajectory? Is it a different treatment? Can you speak English? And that was mainly because I needed to code it. And then most importantly, do you identify as living well? We did have a lady sign up, and then through the process, she actually flared up and she thought, I don't represent your sample, and she withdrew. So we got our 10 super fast. You don't need to look at any of this. I think the key thing I like to just represent is this is the CRPS severity scale. Are those symptoms I talked about on the first slide. Tell us what you're scoring. You know, the average is 5.8 out of 8. So these people that have quite a lot of those symptoms. It was 3 days a week. This is an anomaly. So the person that has zero pain, we just didn't fill out the questionnaire properly. So I did a one-to-one interview. It was about 90 minutes for each. And I said, tell us what living well with CRPS looks like. And then can you tell us what did you do? What milestones did you have? What changes did you make? What reflections? With the idea that we want to use that information to inform people starting this journey, that we can give this to somebody who's newly been diagnosed. And that's why colours are popping out there. What we saw was all the participants described this journey emanating from a time that they weren't living well. And I think that was a really important thing to see, because one might assume that people that live well are always going to live well. You know, they get a diagnosis, they're just this type of person, and they seem to do really well with it. But these guys actually told us that they didn't. What we saw was this idea of living against CRPS was this fight in the medical system, this invalidation, pointless doctor's appointments, treatments, whatever it might be, stigma, self-stigma. And all of them represented that really clearly. But what emerged probably bigger, and this isn't specific to CRPS, is that this idea of not living well was this disruption of one's sense of self. So Megan quite beautifully articulates that, that she had a job that gave her purpose and passion, and losing that job, not only did I lose the psychological income, I felt worthless, felt like I wasn't pulling my weight. So this was the type of thing that we saw. It wasn't so much that I had pain, I had symptoms, my arm wasn't working better, I wanted to cut my arm off, whatever it might be. It was more the fact that I can't do the things that I want to do. I'm not the person that I like, I'm not the person that I was, and I'm not doing my roles in society. We then saw, for however long it took, 6 months, a year, 5 years, there would be a moment, there would be some sort of catalyst, some event that would trigger them to start this journey. It could be trauma. One patient had 4 admissions to ED. John described a point where he got so frustrated he was going to go amputate his hand, and he went down to down to his workshop to go get an axe and cut his finger off. And right as he was about to do it, he had a realization. He said, "What am I doing? This is a turning point where I just had to accept that I had this, and I had to get out of this depressed state." I think that was an important thing for us to see, because at the pain clinic we will see people at their worst, we'll see people at the bottom, and maybe it could be really important to go, maybe this is the turning point where you actually we can start to lift you and work towards living well. We found 3 themes with several sub-themes. This is a longer talk, so don't read the quotes, I'll just talk to them. We did know the first feature in the journey to living well was the sense making. So people needed to make sense of their new life with CRPS. The first part of that was getting a diagnosis and then actually making sense of that diagnosis. That might mean that we get a bit more informed about the condition because people don't know much about it. Maybe it gave an immense amount of validation, and maybe it just gave them this ability to communicate. I don't look sick, so sometimes having an explanation that you can say to other people, something tangible. We know that people then needed information, they needed to see others, they need to hear from others. We know meeting other people was sometimes good, gave them a sense of community. Megan writes here, it's like they've found their tribe, ability to quickly form rapport and to connect quickly so that those people feel heard and seen, importantly, not alone. We also know from the other stuff that a lot of the information online is very unhelpful. It's harmful, probably. You know, Chris talks about it's so negative. It's all about suicide. It's this. So most people avoided seeking information. They got that from health professionals. So what we found is that people needed to make sense of this, what we call evolving conceptual model of CRPS. And our peer review did not like that idea of a conceptual model. But we know that that came in many diverse different ways. Some people it was about neuroscience, it's about nerve sensitivity. Other people it was about stress intolerance. It was about my brain doing bad things. What it kind of consistently was is that it was all different, and actually the didactic style pain education teaching that so much of my profession loves had pretty little impact on these guys. It didn't really help them make sense. John spoke about an interaction with a psychologist here. You know, she said, what you got to do is reprogram your brain, accept it's all like this. And he said, what are you talking about? If you could listen to yourself and say, if I program my brain, my fingers will grow again. You know, these things, they don't really match up with someone's expectations or the way they conceptually think of their pain. And so, you know, we probably thought, actually, we might need to rethink how we teach people about pain, how we educate them. Maybe it's just about sense making. The second theme was this idea about taking control. So we know that people needed health professionals to do that. You know, at PCR, you guys do heaps of excellent research. This will all just be what you know. We know that professionals that prioritized a relationship were way more impactful. There were two bits. Did they look like they had experience? And it didn't matter about your professional scope. So it could be a GP, it could be a hand therapist, it could be a masseuse, it could be a peer. If you knew about the condition and you perceived that that person really valued that person in their care. And then the other one was this person-centeredness. You know, June wrote, I appreciate they saw me as a person. They knew what CRPS was, and they were more understanding of that. They really got it. They could talk to it, you know, they could look at the weird and wonderful things my hand was doing and accept it. And that seems to be a really uncommon thing with CRPS. And you kind of spoke about ED. People arrive, people don't know what it is. They have to tell them. We know that people spoke about these different tools for self-management. What Debbie and I would have loved is that for them to turn up and go, I did this, this, and this, and that really helped me. And then we could go, awesome. You know, we'll do that in every clinic. But the reality is that there was just no consensus on anything that helped. It was all different. Each of them had a self-management toolbox, but they weren't the same. We divided them into symptom relief or restoration of function or psychological well-being or pacing. The person-centered approaches, the key thing they told us is that they wanted to decide, let them trial and error, do that environment that's safe, they can experiment, they can figure out if it works for them. So we kind of talked about this menu, this buffet style that we would approach with them. The one thing, the biggest thing of consensus was this idea of recalibrating a new pace. We were careful not to use the term pacing. You know, that's a taught strategy. Some of these people had not attended pain management clinics, and actually for them it was just this idea about slowing down, reprioritizing, whatever it is. And Chris talked about island time was his reminder. And our last theme, which was probably our biggest one, was this idea about rebuilding a purposeful life with a new identity. So, you know, we learn a lot about acceptance. We were also very careful not to use that term acceptance. We chose accepting. John spoke about this really clearly, the guy that had a aversion to the psychologist's explanation. You know, he said if they can just accept that it's going to be the rest of their life, sure, some people won't want to hear that, they can then start to build around it. It will be different, but they can build and get on with their life and still be productive. Now, that is an interesting idea. What we found really is that, you know, in these patients, it was just that shift from getting myself out of seeking symptom elimination, the cure, living against CRPS, if you will, and the focus towards, you know, living a meaningful life alongside my pain. What Debbie and I found, which again is quite interesting, is that concept of hope, which I know one of your colleagues has talked lots about. Lots of these patients retain the idea of hope. You know, they all thought, if I get the spinal cord stimulator in 10 years' time, it will go away. One day there'll be a medication there. But for them, it was more about, that wasn't the only thing that they were doing. They were focusing on living their life fully, retaining the idea that it might get better eventually. One thing that was quite novel, people with CRPS have to navigate a relationship with a painful limb, one that they often don't like, one that they feel that doesn't belong to them. And we know that that was complex and probably outside of the scope of my talk today. We know that then after accepting comes the rebuilding, and it was the emphasis on rebuilding life. Megan described really nicely about using energy to focus on purpose and passion. And Chris epitomized the idea of focusing on the function, not the form, which is something we saw. So, going to children's sports games and being able to sit on a chair, not ideal, not desirable, but then you can still engage with his kids and still be a good father. And lastly, this idea of reconstructing an identity, a post-CRPS identity. So June described really well something we hear in lots of areas, you're more than your hand or your pain or whatever else, you've got a life outside of that. What we found, which was really interesting, which I don't quite know the answer to, is that all but one of the patients in our study really explicitly rejected the idea of a label of CRPS. They didn't want to be defined by that, which then poses the question about support groups and condition-specific support groups. They wanted nothing to do with it. They just wanted to have a fuller life identity, and so Teresa describes that there. It doesn't, I don't identify with it. So what is it? Living well with CRPS was restored sense of purpose, meaning, and a new identity, accepting the focus and living life alongside a painful limb. It got me to kind of reflect on my own journey. When Debbie and I first met, this was me. It was just myself. And then we had pregnant, and then we had 2 children at the same time, which is a big thing. And then when I handed in my thesis, they're a little bit bigger. And it got me really thinking about what are my foundational values? If I sat there with a condition that was stopping me from being a father or looking after my kids or whatever, would I be all that interested in focusing on pain elimination, or would I be happy with rebuilding that foundational value? So that changed a lot over that time. And Debbie was great throughout that process, being a twin herself. So, sorry, Gwyn, I've gone a little bit over here, but, simmering it all down, we know this is a condition that disrupts one's sense of self. It's not new in pain. With CRPS, it seems to be unique because it's a limb that people hate, and it's there and it's right in front of their face and it doesn't work. So it seems to really do some things about their body image and the way they perceive themselves. Can we prepare those people for a new identity? Can we start that shift a bit quicker? I don't know what to do with this information, but people living well with CRPS rejected the idea of the label. They didn't want to be defined by it. What does that mean with our support groups? Don't know. This is a little bit different to the chronic pain literature, which talks about enmeshment with pain. We can reconnect a limb. That's what we need to do through different various things. So this lady got a tattoo of her foot, which changed the relationship and the way she viewed it. We know people make sense and diverse in different ways, and they often reject this traditional pain neuroscience. Can we actually do sense making in a non-didactic way? Information on CRPS is very confronting and inappropriate, and there are people out there that are working to change this. The right type of support seems to be helpful. We need to offer people with a range of options, let them pick and give them the empowerment to try. Acceptance seemed to be this shift from seeking symptom elimination to restoring meaning and purpose, and people can retain hope. In the pain clinic, sometimes we say, are you still looking for a cure? Do you think this will get better? And often when they say, yep, then we go, I don't really know if you're right for us. I don't know if you're accepting, but maybe that's not actually true. We need to emphasize rebuilding life. OT colleagues are quite interesting. We didn't, this is one of the characteristics of the type of people we saw, but yeah, thanks.
Tim, that was really interesting.
Was that?
It's really
Okay.
interesting to see the complexity of the complex nature of the journey and people's experience and that making sense and drawing on their own kind of knowledge systems, I guess, to figure out what works for them. Yeah, their context. We might see if anybody online has a question, and then I might leave questions in the room for people to chat through afterwards with Tim. But does anybody online have a question or comment for Tim at the moment before we move to Gwyn's? Yes, we've got Karen.
I'll just be quick because I know we are over time. Thank you very much, Tim. I found that very interesting. And my question is, do you think these findings are specific to CRSP, or can they be applied to other conditions as well?
They're absolutely not specific. They're pretty generalizable. I think the difference with this condition, unlike chronic pain, is that this seems to be a heavily medicalized condition. When we look at the research, it's very biomedically focused. It focuses on, infusions and nerve blocks, and it seems to have a much more of a realness over chronic pain. I appreciate how ridiculous that sounds, but you can see it. The arm looks different. It's a different color. It's swollen, which is a little bit different to somebody with, neuropathic or back pain. So I think it's probably novel in the CRPS world, but in a pain world or a chronic condition world, I think it's pretty similar. I'd say that's probably not all that new to most of you guys.
To tag on to that and say, one of the things that struck me is how much similarity there is with the study that we did following people for 2 years after a traumatic brain injury and looking at their recovery and adaptation. There's a lot of similarity.
Absolutely. I think I have a lot of difficulty with this cohort because they are heavily medicalized, and I think TARPs are really good, but I think they're rare, right? I think these infusions and ketamine, and if anybody's a fan of some of the Netflix documentaries, that poor young girl is just seeking ketamine infusions for her pain, and these things they're not that helpful, and so I guess in a world like this, we probably need to shift it less on the biomedical dominance and a bit more to this. Yeah.
Awesome. Cool. Thank you, Tim.
Thank you, Tim.
We're going to move on to Gwyn, who's going to present from her laptop.
Trying to just maximise that. So you guys will be able to see as big as you can. Yep, and hopefully
People online here and see Gwyn.
Can you hear me if I chat from over here?
Yes, thank you. Very clearly.
Cool. We'll try and whiz through. See if I can integrate some of Tim's words into this. Thank you. It's nice to be one of the guest external speakers. I've worked with, supervised with, shared offices with, been across and along the corridor from many people here for many, many years. And I did discover, I've got my research elements page up here. If you look down here, labels, this is what it says. It's a label you can't remove.
What does it say? What does it say? Centre for Person-Centred Research. That's what it means, basically.
The information comes from AUT1 talent pool.
So basically, whether Gwyn likes it or not.
I'm currently hoping it's a member of the team.
It's funny.
So what I'm going to be talking about is the tool we developed, the pictorial representation of illness and self-measure Aotearoa. The first part of it, the PRISM, was a tool that had already been developed. I don't actually like that. I don't like the self and measure part of it. So we added Aotearoa at the end of it. We quite clearly adapted it, so I felt we had to acknowledge that. I also had Debbie. She was excellent.
And she's strong.
So that's the team. So what we do, we wanted to design a better way to assess chronic pain. Currently, there's this suite of questionnaires. There's about 5 questionnaires, which, like most questionnaires, they're lengthy, they're quite complex. They're a really good barrier to people attending chronic pain services. It may not be valid for quite a number of people and cultures here in Aotearoa. So I kind of stumbled across the PRISM and thought, oh, this looks good. We could do that a bit better though. So what we did is work with Māori with chronic pain and Māori clinicians to develop this tool. with the view that what worked for Māori is likely to work for most people better.
Yeah.
What I have put over there are all the things that the tool hopefully kind of does, so we can hopefully cross them off online. They're in the chat, those words. Some of them are a bit contrasting, so you see how well we managed to do all of them. So what I'm going to do is show it on here. I've got it physically and I've also got it online. Hopefully this is going to work. So the tool exists as very high-tech bits of laminated paper. For those online, this here is a laminated A3 bit of paper with some grey concentric circles on it. This is our background page that we have. The circles are for the measurements, which I will get to in a minute. Because this is very flexible, you can do this tool if you don't want the numbers, if you just want the words. And I think the kōrero, the conversation, is what's the important part. But if you want it to be used in our health system, we must have numbers. So you get numbers out of it. If you don't want the numbers, if the chat is all you want, it's very innovative and high tech. If you just want the words, turn the piece of paper over and it is blank white on the other side. You don't need the numbers, and I like that because it's crisper and cleaner. But we'll do that because I know you guys love numbers. We'll do the numbers version. What we need to do first is to define what this is. And I didn't introduce myself because as part of the tool, it encourages whakawhanaungatanga. I have to talk about myself. So whenever we do this, the clinician has to do a bit of explaining and sharing. They always share bits of themselves. So for me, this bit of paper represents my life. So that's me, my family, my work, my friends outside of work, and all the fun outdoor stuff that I do outside of work. And if I were to choose a label, all these bits over here are also laminated bits of paper chopped up. If I were to choose a label, I'd call it my life. But we've got some other labels there. So what does this bit of paper represent for you? And is there a label there that represents that? If not, there's a blank one there, and you've got your fine whiteboard marker with you, and they can write on whatever they want. Now we need to put in what we call the centre disc. So that's what sits in the centre of your life. So for me, and what this assessment's going to be about. So for me, that's me as an individual. And for the centre disc, we have icons, these options here. If I was to choose an icon, I might put this one in here. That's not great because that's in the background. What I might just do is get rid of that. That up here. That's sitting in the centre here. And then I say, but that could be different. For you, it could be you, it could be your whānau, your family, or it could be a community group. Is there an icon here that represents what sits in the middle for you? They can pick any one of them. We also have a blank one. Someone drew a flower on it. Someone wrote faith on theirs. So whatever they see is what sits in the middle. And then we refer, when I do the other instructions, we're always referring to those that label up the top and what they've put in the middle. So, for example, my next question is I'm going to talk about this disc. This is our pain disc, our mamai disc. And what I'm going to ask you to do is to position this disc on the page to represent where pain sits in your life relative to yourself. But you use whatever words they've used and whatever icon they've used, but we'll just use that. So I always have to give an example. So for me, I don't really have any pain. I've got a slightly dodgy elbow, but unless I'm hanging one arm from a mountain, it doesn't bother me. So it's yeah. If it was more part of my life, it would come in a bit closer. It was a big part of my life, but yeah, really close here. So I hand the disc over and say, place this to represent where pain sits in your life relative to yourself. They plonk it down. As soon as they plonked it down, if you're looking at the one with the concentric circles, every circle is 1 centimetre, every fifth one is bolded. You very quietly, without saying anything or doing anything, write down the number. Whatever the circle looks like about, it's highly precise. What line kind of goes through the middle of the disc, write that number down. That's our So we get 5 numbers from this. That's the first one. If they haven't already, you might just ask them, well, why did you position it there? And that normally gets a reasonably short description about pain. You could then ask them questions about what's it like on a good day or a bad day. How much does it move around? Where would you like it to be? Do you know what moves it around? So you can have a bit of a chat about it. It gets them good at bringing things in and using this in a way how it's supposed to be used. And you can just kind of check that their words align with what they're doing with that. Cool. Once that, you've got your number, we take the pain disc off. So now what we're going to add on are 4 well-being discs. For each one of these, it's a different aspect of well-being. So I'm going to explain what that means, and I'm going to give an example, and then I'm going to ask you to position your disc on your page. I normally start with Tinana, our physical well-being, because it's best. I might just zoom in so you can see it's got it written. We've got English and Māori versions there. So what we first need to do, I need to define what this is. This is your physical well-being. This is your physical function, your movement. So what I want you to do is think about the physical activities that are most important to you. So for me, that's about walking my son to school, cycling to work, going off hiking and tramping in the holidays. If I were to position this disc to reflect where they sit in my life, I'd put them in really close in here. They're a big part of my life. I can do them. If I wasn't able to do them as often or as well, it might come out here a bit. And if you couldn't do them, you'd be sitting down here. So then we hand it over and we'll ask them, what does this mean first? So what are the most important aspects of your physical well-being for you? And then position the disc to show where they sit in your life at the moment relative to self. So we might pop them in there. And then what we might do is our whānau, our social well-being. So this is about your relationships. So for me, my most important relationships are with my son. There's just the 2 of us. My work colleagues, my son's school. I use that one as an example. We're always honest in what we're doing. We're being honest, but just to show that it could be about relationships with things and entities. It doesn't have to be about people. So I get on really well with my son. We have a really good relationship. I put up with my work colleagues. Yeah, good. Very honest. So then we ask them, what are the most important relationships for you, and where do they sit in your life at the moment? The next one I tend to do is emotional, hininaro. So this is about your emotional well-being, your happiness, or your sense of joy. So for me, what I like to be pretty chilled about things. I don't like stress and tension. I like to think I've got a reasonable sense of humour. My colleagues might disagree. And I like to be reasonably positive about things. Normally I'm pretty good. I've had quite a few issues with anxiety recently, and this kind of went out over here. I was a bit of a nervous wreck for a while, so it was out there. But that's okay now. I'm not quite so anxious, apart from when I'm presenting to my colleagues. Just got to remember not to picture them naked. Hand it over. What are the important aspects of your emotional well-being? Where do they sit? And the last one, I laid this till last, is the one that the musculo-physios hate, because we've got to ask about spiritual well-being. So this is the wairoa, your spiritual well-being. So this could be in a religious sense, or it could be about your identity, your sense of self, your purpose, whatever it means for you. So for me, I'm not religious at all, but I do have really clear values, and I have a pretty good idea of what I want my identity and who I am and how I do things. And when I had these issues with anxiety, this just fell off the page, off the table onto the floor, upside down. But when that came back in, this came back in as well. I had a really good chance to think about who I am and what I do. And I'm giving this example because I want to introduce the relationship between these things. If they haven't already, it's a really good opportunity to start thinking about how they relate to each other, because we're going to do that coming up. What we can also do is say things like, for me, it was about what helped with that was being up in the mountains, tramping with my son. So these two aspects, which are really close in and strong, that I use those strengths to try and bring these other ones back in. So then we ask them, what does spiritual well-being mean to you, and where does it sit in your life at the moment? And this one's been really interesting. We've had people who have had, these are all sitting well out here. Mostly it's the spiritual well-being that's been in really close. And they've defined it as all sorts of things. They cotton onto it real quick. I kind of do it last because the time they've got through that, they're really chatty and they're really open to this. So they've talked about all different things. And for me, what I've seen is it's that spirituality is what is holding a lot of people together. It's a real strength that doesn't get asked about at all most of the time. So for me, when I give that example of, these ones and were in really close for me, so I use those as my strengths. It's maybe really think about how do we use this one here a bit more. Each time as they've put it down, we've scribbled down a number. So those are the 4 other numbers that we get. So it's very structured. There's those 4 domains, but what they've actually talked about is very much individualizable. Up to them. Have I used all the words on there?
Almost.
One of the other things that I talked about now while we've got them on here is we want to think about, what is the most important one of these for them? Normally we like to have these balanced. So if there was one that was sitting out here, we might think about what do we need to do to get this one in close? Some people have had like this and have just said, I'm just not a social person, so that's fine. And it's like, that's okay. If you're happy with it out there, that's fine. Some people was the same for emotional. They said, I'm not emotional. They had some issues, but they just said, it's fine. It's in my past. I don't want to bring that up, so that's fine. Cool. We might talk about how, when one comes in, how it influences the other one in there. So you can chat about it as much as you want. If you just want the numbers, you've got those. It's fine. Takes about 15 minutes. On average, we record them at the moment because we're doing a validation study, so I've got the recording length. Some go longer, some go shorter. It depends about what they want to do and how you want to use them. But that's essentially the tool, and that's how it works. As I said, we're doing a validation study at the moment to see how well it correlates with the current questionnaires, but also how well the words and the numbers align within there, just to make sure that's fun. And also we're doing some interviews with people who have used it.